We hear this figure of 107,000 Americans dying from drug overdose. We learned just last week that more than 321,000 children have lost a parent to drug overdose in the past decade. I'm working to tackle the illegal production and distribution of this deadly drug like fentanyl from multiple directions through legislation to close loopholes, put pressure on the Biden administration to enforce the laws, hold adversaries like China accountable, and secure the southern border. As co-chair of the Senate Caucus on International Narcotics Control, I'm fighting to permanently classify fentanyl knockoffs. Throughout much of the opioid epidemic, drug kingpins have laced heroin and other drugs with a highly potent fentanyl. We must do more to proactively step up to stop the spread of that. Now, I'm going to follow on a question that Senator Crapo asked about xylazine, and I'm going to ask Dr. Perrone and Mr. Vazena this question. First of all, I'm leading a bipartisan bill that recognizes this lethal threat and provides law enforcement with tools to combat it because it is a sedative and not an opioid. Its effects cannot be reversed by naloxone. That's a standard opioid overdose treatment. So to you two, what effects have you seen in Philadelphia and Oregon on drugs laced with xylazine?
Thank you for that question. As I think I alluded to, it's a little bit confusing, but fentanyl and xylazine are always going together. So 99% of our exposures are fentanyl and xylazine. So when a patient is resuscitated from that kind of overdose with naloxone, they will wake up, they will restore breathing, and they will be revived. They may be sleepy for a couple of extra hours, and so the time to bring them to an emergency department, to support them, to have a peer like Mr. Vazena talk to them when they wake up is really valuable. There's been a lot of talk about antidotes for xylazine. I don't think that that's necessary. To make an analogy, there's medications like Valium and Xanax, which are benzodiazepines. They're not opioids. They make patients sleepy, but they don't stop people from breathing. We have an antidote for that, but we don't use it because it would immediately cause withdrawal, which might be life-threatening. So we have other antidotes for medications that cause sleep, but we don't use them. So really, I want to focus back on naloxone and fentanyl. Those are the deadly drivers of this epidemic. Fentanyl is the cause of people stopping breathing and dying. That's the 107,000 number, the 80,000 number. We need naloxone, and we need to focus on fentanyl. Xylazine has been a problem, but I think it's been a little bit overestimated relative to the huge impact that fentanyl continues to make.
Can you add anything to that, Mr. Vazena?
Yeah, thank you so much. What I would say from engaging people in the recovery process, most people that we work with are not targeting xylazine as their drug of choice. Like the doctor said, it's just included in the fentanyl. And what I've heard is it's a strategy to extend the legs of fentanyl. And what that means is to extend the effect. You know, fentanyl wears off really quickly. When I was using heroin, it would last me about 6 to 8 hours before I would start to go through withdrawals. With fentanyl, people are having to use every hour. And so I think it's a method to put xylazine in there to extend the effect. And so I think, you know, we need to focus on what can we do to help people discontinue fentanyl use. And again, medication-assisted treatment is probably one of the quickest and most efficacious ways to give people a chance to recover. Thank you.
To the same two of you, a few years ago, I suppose about 5 years ago, when I was chair here, I held a hearing that included a discussion on distinguishing between good treatment providers from bad treatment providers. Since then, the federal government has published best practices and guidelines for recovery providers. 5 years later, have we gotten better at weeding out good treatment providers from the bad ones? And if not, why are ineffective efforts and unaccountable treatment providers still in business, and what should be done about it?
The terms good and bad are difficult, but I would say that it's easy if any of us had a child who was suffering from addiction to think that you want to send them somewhere and get them off of everything. That's kind of the detox abstinence model. You may have friends or relatives who have gone to treatment for alcohol. That's an abstinence-based treatment model, and that's very effective for alcohol. For opioid use disorder, we desperately need these medications. Patients may succeed in becoming detoxed off of their opioids, but within days to weeks, they will have cravings and they will get back to that drug. The death rate after treatment in rehab facilities that don't offer medications are incredibly high. We know that the evidence basis supports methadone and buprenorphine, so we can incentivize only reimbursing places that offer these medications. And in addition, these places might offer the medications, but the patient alone may say, I don't want that, I don't want to substitute one drug for another. So we need to re-educate both treatment providers and patients in our communities because there's such a push to abstinence that people just don't understand the evidence. And that's on us, clinicians, to continue to educate everyone. And it's an immediate instinct to think you don't want someone on any medication because you want them detoxed, but that's really just ineffective, and our evidence really suggests we desperately need medications. The long-acting injectable medications that persons would, get once a month would decrease their need to take a medication every day, and that really is supported as well.
The time of my colleague has expired. I do want to brag a little bit about Senator Grassley. He mentioned when he was chairman, some tall guy from Oregon, kind of obscure, was his ranking minority member, and Senator Grassley put together a very important report that looked into the whole question of tax-exempt entities helping to drive up opioid sales while downplaying the risk of opioid addiction. In all seriousness, I was pleased to be able to join you as the ranking minority member, and I ask unanimous consent to put Senator Grassley's important report into the record at this time. Without objection, so ordered. Senator Cantwell.
Thank you.